Yeah. Thank you very much, Vivek, and thank you. As Vivek introduced me kindly, I'm one of the kidney doctors at St. George's, and in the next 40 minutes or so, what I'm going to talk about is cardiovascular workup before kidney transplantation, particularly highlighting on why we do what we do, the aims of the different tests that we do, and after the test, how do we decide who to activate, what interventions to do before we activate patients, or sometimes more importantly, who is the patient we remove from the transplant list because they're too high risk. After that, I'm going to discuss a little bit about the individual tests that we do, like the ECG and the echocardiogram, etc. I am going to talk a lot about the St. George's experience, where this is one of the things that I do in my day-to-day job, and also emphasize on the cardiorenal MDT and the close working between cardiologists and nephrologists to make this whole thing very successful. So, what I will do is I will start with 3 cases, and I would like you to remember these cases when I go on to further discussion. The first one is a patient I had known for quite some time. He's a patient, 55-year-old gentleman with autosomal dominant polycystic kidney disease, had hypertension on 3 antihypertensive medications, had gout. His GFR slowly declined from when I started seeing him, the GFR of 35 to GFR of 19. He was never symptomatic with any cardiac symptoms, and I referred him for a kidney transplant workup to our renal nurse coordinator. Now, my question to you is, what tests would you request in such a patient? Would you be happy with an ECG or an echocardiogram, or would you go ahead and do an abdominal stress echocardiogram or a coronary angiogram? To try and remember this rather low-risk patient. The next patient is a very interesting patient who's a 70-year-old marathon runner, and he run close to 10 marathons every year. He had a chronic glomerulonephritis and slowly declining kidney function. I have known him since 2004. And when his GFR was once again 18, I referred him for a transplant workup. Now, in this avid marathon runner with no history of any cardiac symptoms, what test would you request? Would you be happy with an ECG echocardiogram, or you will go ahead with a dobutamine stress echo, or would you think of a coronary angiogram? So remember this patient, and I'll show you his result as we go along. The third patient is very interesting. He's a Bangladeshi chef seen by my colleague, Professor Oliveira, and referred for transplantation as soon as almost he had seen him. He presented quite late. His diabetes, which was there for a long period of time, together with hypertension, was poorly controlled. He developed diabetic retinopathy, and when he presented, he was near end stage with a GFR of 16. Now, he never had any cardiac sounding chest pain. He was a bit tired and short of breath, and we were not entirely sure whether that was because of the end-stage disease. Now, in such a patient, once again, my question to you is that what would you think of? Would you do an ECG? Would you do an echocardiogram, or go for a coronary angiogram straight away? Because some of the protocols would say that a diabetic who is more than 60 does deserve a coronary angiogram. So try and keep this patient in your mind as well. So going back to the first patient, MH, who is a 55-year-old autosomal dominant polycystic kidney disease patient. We did an ECG, which was normal. And as our protocol dictates, he had an echocardiogram. And you can see the results of the echocardiogram are here. He had a normal ejection fraction. He had no regional wall motion abnormalities, which you can see here. No regional wall motion abnormalities as mentioned on the report, and a mildly dilated left atrium, which is quite commonly seen in our patients. So rather low risk. Happily enough, he was listed, and within a month of being listed, he received a kidney transplant, which was uneventful. So that's the first patient. Then our marathon runner, he kindly gave permission for me to show his picture. He's a gentleman who has been an avid runner for a long period of time, and he is 70. So our protocol says that he has an ECG and a dobutamine stress echo. Now here is his ECG. As you can see, it's quite abnormal. It is with bradycardia, a variable PR interval, and it's a Mobius type 2 AV block. He had a dobutamine stress echo, which was reviewed by Dr. Raj Sharma, whose work I'm going to discuss quite a lot. And you can see here, he had a 3 out of 17 segment ischemia. So in other words, this gentleman has an abnormal ECG and an abnormal dobutamine stress echo. So as our protocol dictates, I referred him to Dr. Manav Sohal, who is one of our cardiology colleagues, an EP expert, who discussed it with him. Him being an avid runner and having this abnormality prompted him to have a dual chamber pacemaker, which was done in December in 2017. And following which, I sent him to Dr. Sam Ferruzzi, who is our liaison intervention cardiologist, and he actually placed a stent in his mid-LAD. And now he's on dual antiplatelet therapy because he has got a drug-eluting stent. So till May, he will be on clopidogrel and aspirin, at that point of time, we can stop the clopidogrel and he can be activated in the transplant list. So as you can see, Mr. CT, who was rather fit, healthy, running marathons, ended up having 2 interventions before going onto the list for transplantation. Fortunately for him, during these procedures of pacemaker as well as his coronary angiogram, he did not develop any acute kidney injury, so we were quite lucky. In fact, we are very lucky with Dr. Ferruzzi, who uses very little contrast and does this procedure as quickly and with as little contrast as possible. Counterintuitively, the gentleman who was 69, poorly controlled diabetes and hypertension, the Bangladeshi chef, he had a normal ECG and a normal dobutamine stress echo, as a result of which he was immediately listed for transplantation. He is still active on the wait list, but he had a general anesthesia for his fistula formation, which he tolerated very well. So you can see a spectrum of patients, starting from a low-risk patient, MH, who had a normal ECG and a normal normal echocardiogram and was transplanted successfully. You've got Mr. NS, who is quite high risk, did require a dobutamine stress echo to be listed, and in between we had Mr. CT, the avid marathon runner, who ended up having 2 procedures and still waiting for another 2 months before he can be activated on the transplant list because of his dual antiplatelet therapy. So try and keep these 3 patients in mind while I discuss what I'm going to discuss. The next question is, why do we do this intense cardiac workup before transplantation? And the reason being is the presence of cardiovascular disease in end-stage renal disease patients and CKD patients who are approaching dialysis and getting workup for transplantation are not very far from it. So there is a very high risk of coronary artery disease, up to 42%, heart failure, both systolic and diastolic put together about 40%, and peripheral vascular disease, which makes these patients very high preoperative risk. Also, there is a year-on-year very high incidence of cardiovascular events with acute coronary syndrome, mostly non-ST elevation MIs, incident heart failure, stroke, and arrhythmias with sudden cardiac death. And as you can see here, the risks are pretty high. There's quite a few studies that I put together to get to these figures. You can see that the risks of acute coronary syndrome, incident heart failure, and stroke is around 2 to 2.5%. And the incidence of sudden cardiac death is pretty high, 5% in prevalent dialysis patients, and perhaps up to 7% in incident dialysis patients. So very high cardiovascular event rates. Hence, we do a cardiovascular workup. And the aim of that, as Professor Jha discussed in the beginning, is to minimize the perioperative risks. i.e. identify the risk and manage accordingly before they are listed. We also want to avoid transplantation in very high-risk patients, and these patients should be informed that it's better for them not to be listed. We also, in our mind, have the idea that with the cardiovascular workup, we are going to prevent cardiovascular events pre and post kidney transplantation. So these are the three main aims of a cardiovascular workup before kidney transplantation. And after this workup, depending on what we find on the test, the outcome can be A, the patient is allowed to proceed for transplantation with minimal investigations, as we saw in our patient MH, or B, they undergo either a PCI, coronary artery bypass graft, and a valve operation if that's needed before they are listed. And a good example is Mr. CT, who ended up having a drug-eluting stent in February before he could be listed. It also prompts us to use the statins, the antiplatelets, mainly aspirin and beta blockers as indicated to decrease perioperative risk. In some cases, it will either delay the transplant operation or even cancel the transplant operation and patient removed from the wait list. And I think this also benefits patients quite a lot, particularly the high-risk patients who are not likely to do very well with the operation. It also gives an idea of the patients who remain high risk despite intervention, who requires intensive monitoring intra and immediate post-operatively. Now, we have got an anesthetist, Dr. Nicoletta Fossati, who is very keen on monitoring these patients with a transesophageal Doppler during the operation. And these patients who remain high risk despite interventions do go to high dependency unit post-operatively for at least a night before coming to the regular ward. So these are the possible outcomes after the cardiovascular workup. One of the first and most important steps in the cardiovascular workup before kidney transplantation is the perioperative risk stratification. Now, this is very, very important, and you can see that we can use lots of different types of indices or risk stratification scores. And here is an example from Dr. Lee, where he used these 5 different features: presence of ischemic heart disease, history of cerebrovascular accident, heart failure, diabetes as renal failure, and renal failure. And as you can see, the number of risk factors that it goes from 0 to 1 to 2 to 3. The risk of perioperative event rates are rising, as you can see, and patients who have 3 or more of these risk factors have an event rate of 11%. So that's not insignificant, and this is what we are trying to avoid in our patients. The perioperative risk is mainly related to the operation itself, and the operation induces tachycardia, hypertension, causes large fluid shift sometimes, hypotension, particularly if there is bleeding, and also induces hypercoagulability. And all of these causes myocardial ischemia, arrhythmia, and heart failure in the very high-risk patients. So this is what we are trying to prevent. Now, what are the guidelines which are available, which gives us guidance regarding what to do with cardiovascular workup? There are several of them, as listed on your left-hand side, but the most recent one, the European Best Practice Guideline, is shown here, and they have a very stepwise approach. If the patient has any of these high-risk features like age more than 50, history of cardiovascular disease, diabetes, or family history, they undergo a transthoracic echocardiogram and an exercise test. And if these are abnormal, they go ahead and have a cardiac stress test, which if abnormal, they have an angiogram, which if abnormal, they have a revascularization therapy. And if these tests are normal, they can be listed for kidney transplantation. So this is very similar to what we have been talking about, but every unit have their own protocol. It's very similar to what is shown here. So for example, at St. George's, our protocol is something like this. we stratify patients to minimal risk, who have age less than 40 and none of the other high risk factors, or low risk where they're between 40 and 60, and a very high risk when they have age more than 60, diabetes, history of ischemic heart disease, heart failure, or peripheral vascular disease. Now, the minimal risk patients have an ECG and a transthoracic echo, and if they're normal, they get listed. The low risk patients have an exercise stress test, which if negative, they have a echo and get listed, which if positive, they go ahead and have a dobutamine stress echo. The high-risk patient, and all of the high-risk patients, including the gentleman, the Bangladeshi chef I was talking about, will undergo a dobutamine stress echo and not a coronary angiogram. And they will only have a coronary angiogram if the dobutamine stress echo is positive, which is usually in 30% of our patients who have dobutamine stress echo. However, if a patient does have angina, they go and see the cardiologist, and if convinced, they go and have a coronary angiogram straight away. And this can happen anytime during the workup or even after they're listed. So this is a protocol that we follow at St. George's, which you can see is somewhat similar to what I talked about from the European best practice guidelines. Now, talking about the recent studies on cardiac workup. Now, the studies are quite limited, and they're mainly observational. And the numbers of patients included in these studies, you can see, are not very many. One of the largest one of these are Nikki Kumar study from one of our neighboring transplant unit at Imperial College, which had the largest number of coronary angiograms by 2011. So I'm going to talk a little bit about some of these studies later on, including a recent one from our group with 258 patients and 42 coronary angiograms. Now, going to the individual investigations. So firstly, why do we do an electrocardiography? Now, a standard 12-lead resting ECG is very, very useful at times because it picks up conduction abnormalities. And a bright example of that is, as shown here, Mr. CT, who had a type 2 heart block and required a dual chamber pacemaker. But quite frequently, we do pick up arrhythmias, particularly atrial fibrillation, and then we think about anticoagulation. We do occasionally pick up patients with white QRS and interventricular conduction defects, and sometimes STT wave changes suggestive of ischemia, which sometimes prompts to dobutamine stress echo or an exercise stress test, depending on the patient's age. So a static resting ECG is very useful. But sometimes from resting ECG, we are prompted to do a dynamic ECG, usually a 24-hour Holter monitoring, to see if the patient has particularly symptoms of fainting, dizziness, or palpitations, to see if is arrhythmia contributing towards it, which might require intervention before the patient is listed for transplantation. The next test that we do is an exercise treadmill test in a lot of our patients, and this is quite useful. Now, let me take you through the utility of our exercise stress test. One of the very important features of this exercise test is that the patient has to have a certain functional ability to complete the exercise stress test. And if they can exercise up to 6 minutes, which is the second stage of Bruce protocol, that definitely indicates that they have a good functional, reasonably good functional status. And that is shown here in this particular study, where you can see that patients who could exercise more than 6 minutes had a better survival over a period of 5 years, as opposed to patients who could not exercise more than 6 minutes. So this is a good functional test. It also picks up ischemia, which the exercise treadmill test is for, with the downsloping ST segment depression, as you all know. But here is the problem. A lot of the patients, particularly if they are young and the chance of having coronary artery disease is low will have positive stress test. And that sometimes creates more problems because they undergo abdominal stress echo and occasionally a coronary angiogram, which causes real problems. So next is a transthoracic echocardiogram, which most of our patients do get. Now, this is done to pick up a few things, including a low ejection fraction, valvular abnormalities, and regional wall motion abnormalities. And a very good example is a patient of mine who had a loud systole-diastolic murmur. This is a 48-year-old female with reflux nephropathy. When we picked up a loud murmur on auscultation, she ended up having a significant aortic regurgitation and has recently had a valve replacement. One of the key investigations is a cardiac stress test, and there are two forms of cardiac stress test which are used commonly. One is a dobutamine stress echocardiogram, which is very common in our institution, and in fact that's the only cardiac stress test that we use in our institution. And two, myocardial perfusion test, which is frequently used as well. The dobutamine stress echo is particularly important to say that it is operator dependent. Now, the evidence of dobutamine stress echo comes from studies from Charles Herzog and Tom Marwick in Minnesota quite a while ago, where they had shown that patients with positive dobutamine stress echo have a poor prognosis. This was quite a high proportion of diabetics, and half of the patients were DSE positive, followed up for 22 months. As you can see, the event rates in dobutamine stress echo patients are very, very high. A similar feature was noticed by Raj Sharma, one of our cardiologists who I spoke to you about in the past. He in this study of 125 patients followed up in early 2000, you can see that patients with a positive dobutamine stress echo had a poorer survival compared to the patients with negative dobutamine stress echo. And this is very similar to this study. However, here it's not statistically significant. In our recent evaluation of our protocol, we've seen that it holds similarly true that the patients who are dobutamine stress echo has a poorer event-free survival. So they had event rate of 17.6% as opposed to 8.6% in the patients who were dobutamine stress echo negative. And the annualized event rate in dobutamine stress positive patients is 11%, which is more than half in the dobutamine negative patients. So it is a good predictor of poor outcome in follow-up. Also, it is better than exercise test, abnormal ECG, or chest pain in predicting coronary artery disease. And this is a study from Raj Sharma, once again, 125 patients followed up for 1.6 years. And you can see that compared to chest pain as a symptom, abnormal static ECG, positive exercise test, or positive dobutamine stress echo, the dobutamine stress echo is much more sensitive and predictive in our hands. And it is also much more predictive and sensitive compared to resting wall motion abnormalities that we see on transthoracic echocardiogram. So it's a very good predictor of coronary artery disease. Now, head-to-head comparison between dobutamine stress echo and myocardial perfusion scans are not very many. And when trying to do a meta-analysis with the limited studies that we have, this Australian group showed that perhaps the dobutamine stress echo has a slightly better sensitivity and specificity and a better ROC curve compared to the patient myocardial perfusion scans. Now, here's the caveat. I mean, dobutamine stress echo is operator dependent, so one should remember that when trying to choose between the two. Coronary angiogram. Coronary angiogram is a very good predictor of adverse outcome. And this evidence comes from, once again, Chuck Herzog and Tom Marwick study way back in 1999, where they showed that the patients with more than 50% stenosis have a much poorer outcome than compared to patients who have less than 50% stenosis. And that's true for the cohort that Raj followed in the early 2000s, 125 transplant candidates for 1.6 years. You can see patients with a lesion less than 70% has a better survival than patients who with a lesion more than 70%. This brings us to the question, how useful is coronary intervention? Now, here, the evidence is really limited. I'm going to show you two studies which are on this particular panel. You can see the one on your left is a study by Nikki Kumar from Imperial College, and they followed up 657 patients, and out of those 168 had interventions because of obstructive coronary artery disease. And they had a group of 18 patients, interesting 18 patients, who despite having obstructive coronary artery disease declined intervention. Now, the reason for intervention was not given in the reason for declining the intervention is not given in the paper, but you can see that those 18 patients showed in this particular line had a very high event rate as opposed to all the other groups, including patients who had intervention, patients who had non-obstructive coronary artery disease, or patients who had normal angiogram. So it implies that doing an angiogram, which this particular group does in all patients referred for kidney transplantation, might be useful in picking up patients with obstructive coronary artery disease and doing interventions to get rid of the obstruction. A very similar study is shown here. In this particular study, 229 patients had angiogram, and you can see that patients with obstructive coronary artery disease who did not have intervention, which is the bold black line, had the worst survival rates compared to the other groups. So once again, you can see that both the studies are kind of suggesting that coronary intervention is useful. However, our experience has been slightly different. So whether patients after a positive coronary angiogram and a significant coronary artery disease has revascularization and not, did not make a huge difference to our population. So this is the patients who had no percutaneous coronary intervention or coronary artery bypass graft, as opposed to these patients who had percutaneous coronary artery intervention or bypass graft. You can see their event rates are even higher. But these are very, very high risk patients with an abnormal DSC and an abnormal coronary angiogram. So hence, despite having intervention, they continue to have a higher mortality and event rates. And you can see that a lot of the events, there were 14 events, there were acute coronary syndrome, CVAs. Only one of these patients was actually transplanted, which is quite significant considering the amount of effort that was put behind these patients to get them fit for transplantation. So if I summarize the entire process of how do we do the cardiovascular risk stratification and then the subsequent test, it can be simplified as shown in the diagram. The first most important step is the risk stratification. It looks like that the patients who have low risk or very low risk, they tend to do very well. They have very low event rates. Perioperative event rates are very close to zero, as opposed to the high-risk patients who does require a lot of interventions. This risk stratification is followed by a simple ECG and then, when necessary, an echocardiogram, which is then followed by a cardiac stress test, which is usually a pharmacological stress test like a DSC on MPS, and some of the patients will undergo a treadmill test. And then when these tests are positive, they will have a coronary angiogram, which may or may not require an intervention, followed by listing for transplantation. Now, the last thing that I wanted to talk to you about is management of the patients in the wait list. So what do we do with the patients once they're listed for transplantation? Now, there is no protocol and there is no guidance, and every unit does it slightly differently. Probably most units would be reviewing their patients every 2 to 3 years. We, in our protocol, decided that we are going to review the low-risk patients every 5 years, and the high-risk patients are reviewed in a multidisciplinary team every 2 years. And most of the times they end up having another cardiac stress test. And this is the recent analysis of 164 high-risk patients who went through the cardiorenal MDT 2 years after their listing. And you can see here, 40% of the patients did require more workup. 44% patients remain active on the list. 12% of the patients who perhaps had completed whatever they needed to complete were activated as agreed by the nephrologist and the cardiologist. But more importantly, 4% of the patients, as shown in this bit of the pie, were actually removed from the transplant list. Now, this is very important because these patients were very, very high risk. And being on the transplant list and undergoing a transplantation was not at their best interest. So even by careful monitoring during the operation and taking them to high dependency unit, it was felt that they will be very, very high risk and it's not worth taking. So they were advised against transplantation, and their nephrologist took the message back to the patient and discussed that this was the decision of the MDT, and the patients were happy with it. I have shown here a tree diagram of the patients who had procedures after the MDT, of the 126 patients who were decided to have further procedures. As you can see, most of them had dobutamine stress echoes, 61 of them. 5 had exercise stress echocardiogram, 13 had coronary angiograms, 4 underwent PCI, and 4 had coronary bypass graft. Now, the choice between PCI and CABG is as in the clinical practice guidelines for these revascularization procedures. So anybody with a left main stem disease or triple vessel disease, particularly with a low ejection fraction, or a proximal LAD disease with low ejection fraction, would be undergoing a coronary bypass graft, but other patients would be offered PCI with single or two vessel disease with a maintained ejection fraction. We are very fortunate that we have a team of cardiologists who are very happy to do these PCIs with minimal contrast agents, and we have a group of cardiothoracic surgeons who are also quite receptive to our patients and would offer them surgery within weeks to make sure they are fit for transplantation as early as possible. One more thing about the PCI is the choice of the stent. So if a patient has to be listed quickly, they would have a bare metal stent and have a dual antiplatelet therapy for 1 month only, and they can be activated at the end of the month after stopping clopidogrel and continuing with the aspirin. Whereas patients with complex lesions and diabetics would have a drug-eluting stent, as you saw in our patient, Mr. Tyrell. And in these patients, ideally the dual antiplatelet therapy should be given for 1 whole year, but it changes according to the patient's need. So as I mentioned with Mr. CT, Dr. Sam Faruzi has advised dual antiplatelet therapy only for 3 months, and then he can be activated on the list. So the choice of the stent, whether it's going to be bare metal stent or drug-eluting stent, depends on how quickly you wish to list them for transplantation and whether they have a live donor available. If there's live donor available, of course, we wish to proceed with the transplantation as soon as possible. What is very important in this whole process is to have a multidisciplinary approach and a close collaboration between nephrologists and cardiologists and the transplant surgeons is very important. The nurse coordinator who organizes these is also very important. So in this picture, you can see Dr. Sam Ferruzi, who is our intervention cardiologist, who joins our cardiorenal MDT. Dr. Sam Ferruzi, Dr. Raj Sharma, who is our non-intervention cardiologist, does all our Doberman stress echo, and he joins the cardiorenal MDT as well. Sister Maria Fernandez here, who organizes the cardiorenal MDT and manages the patient on the work list together with a few other of our team members to look after patients like Mr. CT to make sure that the cardiac transplant is done and completed in a very short period of time, everything that needs to be done, and then the patient can be listed for transplantation. So in conclusion, what have I told you? I've told you that cardiac workup pre-transplantation is necessary to minimize perioperative risk and also risk pre and post-transplantation. Perhaps one of the most important steps is risk stratification, because that guides us to the next step, what is necessary. A static resting ECG, 12-lead ECG, is very, very helpful, as you saw in the case of Mr. CT. The low cardiac risk patients tend to have very few events and perhaps requires an ECG with or without an echocardiogram. On the other hand, the high risk patient definitely benefit from a cardiac stress test because it has both prognostic and diagnostic utility, and it then prompts a coronary angiogram. Coronary angiogram is useful in patients with positive stress and if they have angina, and if it shows obstructive coronary artery disease, perhaps we should go ahead and do PCI or CABG to minimize their risk, as you have seen from a couple of studies that I've shown you. However, very importantly, the high-risk patients should be advised against transplantation. Thank you very much. I'll stop there and show you